Thank you to the organizers and directors for the opportunity to speak. I'm a vascular medicine specialist at Mount Sinai. I'm the program director for our vascular medicine fellowship, and I'm going to be speaking about diagnostic testing and physiologic assessment of PAD. These are my disclosures, none really relevant to today's discussion. I have two objectives for you. First will be to understand the strengths and limitations of non-invasive testing for PAD, and second, to select the appropriate test for your patient with PAD. So we'll start with a case. This is a 78-year-old woman with leg pain. She's a vasculopath. She's had PCI in the past, hypertension, COPD, and is a current smoker. She's complaining of bilateral cramping pain left more than right when she ambulates any distance. Her medications are listed there. And I want you to take a moment to think about what type of questions you would ask to tease out the cause of this leg pain. I'll tell you, she gets leg pain at night sometimes, and she also reports numbness and tingling radiating from the hip to the foot. She got a lower extremity arterial duplex, which demonstrated a 20 to 49% stenosis in the distal SFA on the left. The right side was fine. So it's important to think about how you sort out leg pain when you see the patient in front of you, and there's nothing better than the history to do that. So remember, with PAD, the typical intermittent claudication is exertional and reproducible, although only a minority of patients will present with this classic syndrome. The second mimicker is spinal stenosis. It can be exertional, it can be positional, particularly with standing, and it's not relieved by rest alone. And it is so close to intermittent claudication that we term this pseudoclaudication. Then lumbar disc herniation, typically with some radiating pain, worse with exertion and can linger. Osteoarthritis, joint pain that may radiate. And then venous claudication, which is an exertional tightness or bursting pain that really lasts a long time, often more than 15 minutes. So this is the spectrum of PAD that we're familiar with. Keep in mind that typical claudication is only about a third of patients. The majority are going to be asymptomatic or atypical symptoms. And the smallest amount, thankfully, will present with critical limb-threatening ischemia, which is a syndrome of rest pain, gangrene, or ulceration due to PAD. Now you can think about the symptoms as reflecting the level of involvement. You'll typically have symptoms one level below the area of disease. So buttock and thigh claudication for aortoiliac, thigh or calf for SFA pop, and then calf or foot pain for tibial peroneal disease. And the frequency of involvement is listed here. You'll notice it doesn't add up to 100% because people can have multi-level disease. So how do you evaluate the patient with PAD? There's really two arms. There's physiologic testing, which is a functional assessment, and it's going to tell you if there's an arterial flow problem. And for that, we've got our ABI, pulse volume recording, segmental pressures, and continuous wave Doppler. And this can be performed at rest and with exercise, which is going to be really useful. And then imaging, which allows us to actually see the lesion anatomically. And for that, we can use duplex, CT, MR angiography, or catheter-based angiography. So if we start with the ABI, this is the cornerstone of the PAD diagnosis. It involves taking the ankle and brachial systolic pressures using a Doppler sensor, and we need to take the highest of the ankle systolic pressure, either the PT or the DP, over the highest brachial systolic pressure, either the right or left side. And the reason we use the highest is because it's the most specific for the presence of disease. And this consistently outperforms either the pulse exam or the Rose questionnaire, which is a series of questions basically asking for symptoms of intermittent claudication. So it's the best diagnostic tool that we have. The threshold for normal is an ABI of 0.9. Normal is really between 0.9 to 1.4. We do call borderline from 0.91 to 0.99. And then calcified if our ABI is greater than 1.4. So if we use this patient example here, we can see that the right systolic pressure, brachial pressure is 160, the left is 120. So we're going to take the highest, 160. And the reason is there's a pretty big differential here, so there's probably left subclavian axillary disease. For the pressures at the ankles, we'll take the DP on the right, which is 80, and on the left, 120. So we get a right ABI of 0.5 and a left ABI of 0.75, indicating the presence of disease. So what are some limitations of the ABI? Well, one, it doesn't localize the level of disease, right? It just tells you there's a blockage somewhere between the arm and the ankle. How can we get around that? We can get segmental pressures, and we'll talk about that. 2, what about variability between exams? What's within the error? You're looking for a change of more than 0.15 between exams to say that there's been a real improvement or worsening of disease. Now, what about calcification and vessel non-compressibility, especially important for our diabetics and end-stage renal disease patients when the ABI is greater than 1.4? Well, we can use the toe brachial index. An abnormal toe brachial index is less than 0.7. Now, there's argument that there's poor sensitivity in mild disease. We talked about that borderline range where it's, maybe abnormal or close to abnormal. How do you distinguish if there really is disease present? You can exercise the patient and bring out disease if the ABI is normal at rest. And remember that a post-exercise decrease in the absolute ankle pressure of 30 or a decrease in the ABI of 20% is what you're looking for if the ABI is normal at rest. Now, it may be falsely normal in the setting of critical and threatening ischemia. This is really important. And so in that setting, you may ask the lab preemptively to get the TBI or look at other markers of microcirculation, the TCPO2 or SPP if you have access to that. So here's an example of segmental pressures. We have a patient with brachial pressure on the right of 125, on the left of 146. So we're going to take the higher, 146. We'll start with just taking the ABI. So on the right, that's going to be the higher 0.87, and on the left, 0.83. So they're both abnormal. So now we want to find the level of disease. We're going to look for a drop of 20 between the segments to say that that's the level of disease. So if we start with 146 and come down at the thigh, not quite, 143, 137, and then 114, 117. There's our drop. So we've got bilateral SFA popliteal artery disease. What I showed you here is the 3-cuff method. So you've got a thigh cuff and then 2 below the knee. And this is paired with a continuous wave Doppler at the level of the femoral artery, which should be triphasic if it's normal. Let's say the drop was at the thigh. That's where that continuous wave Doppler becomes important, because if it's abnormal at this level, it's going to tell us that there's aortoiliac disease rather than common femoral or proximal SFA. There are some centers that use a 4-cuff, which are 2 cuffs above the knee, rather than the continuous wave Doppler, just so you're aware. Now, those pulse volume waveforms are also important. They're another adjunct to our test. The pressure always will out-trump the waveform because they're more subject to artifact, but it's important to keep in mind, basically the cuff is partially inflated, and then this measures the volume displacement of blood flow with each contraction. So you should get a rapid upstroke in systole, a dicrotic notch mirroring that triphasic waveform, and then coming back down. The first thing to go in the presence of disease or calcification is the dicrotic notch. After that, you can start to see parvus tardus waveforms or severely abnormal waveforms. Okay, so here's another example of an ABI. We've got a right brachial pressure of 141. The left is 137, so we'll use the 141. And taking the higher ABI between the PT and DP, we have 1.08 on the right and 1.1 on the left. Our waveforms are pretty decent. We've got a little dicrotic notch here on both sides. So now we had the patient exercise to bring out disease because he was complaining. I'm sorry, this is the patient I started with. She was complaining of that bilateral leg pain, right? So she was exercised at a 12% grade and had to stop because of bilateral left pain, left more than right. And what you can see is that there was a minimal drop on the right. The left was actually normal. It went up with exercise as expected on the left-hand side where she was reporting symptoms. We did not see a drop of 30 millimeters of mercury, nor did we see a 20% drop in the ABI. So this is technically normal with exercise. And again, we didn't reproduce the patient's symptoms. So she has PAD because we visualized the lesion, but it's not causing her pain. This is an opportunity to optimize medical therapy, which we're going to talk about more later on this morning, but very likely she needs to be evaluated for other causes of her leg pain. So what if you don't have a treadmill? How can you exercise the patient? Or let's say, they can't walk prolonged distances. Well, you can actually do toe ups. So you have the patient toe up 1 per second. And there's good data actually showing that this is reproducible and mirrors what you see with pre and post treadmill exercise testing. So find out if your lab is doing this wherever you are, or talk to them about getting a protocol in place. Okay, next patient is a 69-year-old male with left leg ulcers. He had bilateral occlusive DVT with post-thrombotic syndrome. He's had leg ulcers for more than 5 months that are non-healing. They become more painful recently, especially at nighttime. He's had PCI to his LAD in the past. He has hypertension, hyperlipidemia. And in terms of medications, he's on anticoagulation, high-potency statin, beta blocker, and lisinopril. Here's what his ulcer looks like. You can see some sequela of venous disease, some hyperpigmentation, lipodermatosclerosis, and ulcer over the malleolus. But because this was a non-healing ulcer for so long, I decided to get some arterial testing. And what we can see here is his ABI on the right was 0.9, so borderline. On the left, 1.24 for the higher. But for those in the back who can't see, the DP is 0.66, so there's a pretty big difference on the left between the PT and the DP, which can be a sign of calcification. I asked the lab to get TBIs, and sure enough, his TBI on the right was 0.51, and on the left it was 0.38. So reduced TBIs bilaterally consistent with PAD on top of his venous disease. So it's important to keep in mind different types of ulcerations. You guys are probably very familiar with critical limb ischemia, atheroembolization with distal ulcerations, sometimes some livedo changes, venous ulcers, which tend to be wet with a predilection for the gator area with hyperpigmentation, and then neurotrophic ulcers that occur over pressure points. But about 26% of patients that have a leg ulcer are going to have both PAD and venous disease. And this is really important to keep in mind because the PAD may limit your ability to adequately treat the venous disease with compression. So you need to make sure their ABI is greater than 0.5 or their absolute ankle pressure is greater than 60 before you apply compression. Otherwise, you might make things worse for them. Now, this is some data showing that the ABI is a difficult measure in patients with CLI. So for patients with CLI out of a center in Michigan, or 47 sites in Michigan, the ABI was normal in about 20 to 25% of patients. So you need to have a high index of suspicion. You need to think about using the TBI to further evaluate for the presence of critical limb ischemia if the ABI is normal. So what can you do? Again, the TBI cutoff is 0.7. This works because the smaller vessels are not subject to calcification as much as the larger vessels are. You'll probably hear about some other measures, and they're making their way into the guidelines now for transcutaneous oxygen pressure and skin perfusion pressure, which are other measures of microcirculation. The issue with these is they're not widely available, and they're also limited in a variety of clinical settings, including heart failure, pulmonary disease. But you will see those in the literature. So when should you image? I talked a lot about ABI. Well, I would consider it when you're thinking about intervention or whether or not your patient would benefit from intervention. And any one of the modalities, duplex MRI, CT, or catheter-based angiography, have good sensitivity and specificity. There are limitations with duplex. It's definitely operator dependent. You get shadowing with calcified vessels, and you may be limited in multi-level stenosis. With MR, you can get dropout in the presence of critical limb ischemia. You're going to hear more about imaging with MR and CT from Dr. LaRocca. And then with CT angiography, heavily calcified vessels may cause blooming artifact. Catheter-based angiography we really use for the most part when we're thinking about intervention. All right, last case I'm presenting. This is a 70-year-old male with intermittent claudication. He had a reduction in his exercise tolerance over the past 6 months due to bilateral calf and thigh claudication. He went from unlimited to less than 5 blocks. Definitely a vasculopath. He's had 2 heart transplants, a kidney transplant, diabetes, hypertension, hyperlipidemia. On exam, he has a right cervical bruit, a periumbilical bruit, and has pulses intact with normal skin findings. Here's his ABI. So higher brachial pressures on the right at 140. ABIs bilaterally are actually within normal limits, so 0.9 on the right, 1.24 on the left, and reduced toe brachial indices, 0.51 and 0.38. Patient was exercised, And it went 7 minutes, and we reproduced that bilateral calf pain and had to stop because of it. So if we look at the absolute ankle pressures on the right, we went from 126 to 85. On the left, 174 to 119. So definitely reduced with exercise. We ended up doing some ultrasound imaging, and what we were able to detect is a bilateral common iliac artery stenosis in the 50 to 99% range. You can see on this view that there's turbulence in this area. There's definitely calcification with that hyper intense signal and elevated velocities with a monophasic waveform. So the patient was sent for angiography because inflow disease does much better with intervention up front, and they were found to have a distal infrarenal aortic stenosis of 15, bilateral common iliac artery stenoses, and a right external iliac artery stenosis. And you can see the kidney transplant is coming off the right side. So we want to preserve that in addition to improving the patient's symptoms. So he underwent bilateral common iliac artery stenting. This is the post-ABI, which is now normal at rest, 0.92, 1.09. And with exercise, all of the pressures went up, and he didn't have any symptoms in the legs. So when do you repeat physiologic testing? If the symptoms are stable on follow-up, there's some debate as to whether or not you should repeat testing. I will say that sometimes patients will start to limit their exercise without realizing they're doing it. So it's a nice objective way to see if there's a decline over time. If there's new or worsening symptoms, you definitely want to get the ABI up front to see if there's been a change physiologically. Post-revascularization, we get a baseline ABI with exercise, which is supported by the guidelines. And then duplex is reasonable for routine surveillance of endovascular intervention or bypass. We typically do that. And as you can see, oh, sorry, that's second. This is an example of what in-stent restenosis can look like on imaging. So we can see the stent edges here, incomplete filling of the stent with turbulence in that area and elevated velocities. Now, in terms of endovascular failure, the duplex parameters don't reliably predict failure, so you have to keep that in mind. And there's a tendency to develop symptomatic restenosis more than bypass patients, and lesions are more likely to stabilize or regress over time. In terms of duplex for bypass grafts, we look at inflow, the bypass graft, and the outflow vessels. The modes of failure are different depending on the timing, which is important to keep in mind. Early on, it's probably technical failure or a hypercoagulable state. Intermediately, you may get intimal hyperplasia, and late, probably progression of athero in the inflow or outflow vessels. In terms of vein grafts and the data, duplex has not been associated with a significant improvement in the primary or primary assisted patency, secondary patency, or mortality. But because it's non-invasive and low cost, SVS guidelines do suggest the use of duplex with ABI in the clinical examination. And there are some parameters that can identify a graft that's at high risk for failure, namely a peak systolic velocity over 300 or a velocity ratio of 3.5. In terms of prosthetic grafts, there's also no evidence that surveillance is effective in predicting graft failure, but there's some evidence that low graft velocities are associated with a higher risk of thrombosis and may support the initiation of anticoagulation. So SVS guidelines again suggest providers use duplex in the ABI with the clinical examination, and typically it's 6 months, 12 months, and annually. So in summary, thinking about the goals of the PAD evaluation and how your testing can help you. If you want to know if the patient has disease, I'd advocate for physiologic testing or imaging to identify the presence of PAD. If you want to know where it's located, imaging will outperform physiologic testing because you'll actually visualize the lesion. If you want to know if the disease relates to the patient's presentation, physiologic testing will tell you that. You're going to reproduce the symptoms and actually demonstrate that it's related to the PAD. If you want to know what your therapeutic options are, imaging is the better diagnosis to help you to understand that. And if you want to know what your results of therapy are, physiologic testing is the best test to get a baseline, demonstrate improvement, and follow the patient over time. And with that, I thank you very much for your attention.